We are delighted this morning to have Andrew Kurtz with us as our speaker. He is an eminent professional in substance use and treatment of the seriously mentally ill. And he comes to us from the UCLA program, which specializes in this. He also is a licensed marriage and family therapist. We are quite delighted to have him because this is a specialty area that is so specific to many of your populations, and the supervision of it is highly complex.
Thank you, Dr. Fallender. I really appreciate everybody being on today. As we go through today, I will certainly tell you about some of my experiences. I'm happy to share all of that, but I really feel like this is an opportunity for me to hear about some of the different challenges that you all are experiencing, and hopefully provide some degree of consultation, some degree of support, and information around how you might be able to proceed. But also this is a chance for you to work with your colleagues who are on this session with us. There are quite a few people on the session, which is great to see. I think one of the best uses of this kind of technology medium is really to have a chance to talk to one another and see what everybody's doing and how they're doing it, what kind of successes they're having. So as we go through today, I hope you take the opportunity to do that. This is just an intro really quick. I'll come back to this, but I want you to make note. We're gonna use Poll Everywhere at the outset of the training. And so if you haven't used this technology before, just read through this really quickly. There's gonna be one activity that we'll be doing there. All right. So today we're talking about challenges in clinical supervision. We're really going to focus on the intersection of substance use disorders and mental illness. We originally conceptualized this to think about serious mental illness, but as I was putting this together and as I've worked with different providers, I've come to realize that most of the providers in community mental health, community behavioral health are seeing serious mental illness. That's kind of the default impairments that we're seeing with clients who are coming in. And so we're going to think about that intersection as we move through today. Again, just to orient you to what we're going to be doing, we're going to be together for the next 3 hours. We'll take a break midway through, about 15 minutes, and I'll kind of update you on timing as we move through. A little bit about me, again, as Dr. Fallender said, my name is Andrew Kurtz. I'm a licensed marriage and family therapist. My pronouns are he, him, and his. I'm a clinical specialist currently with UCLA Integrated Substance Abuse Programs, which is a department within psychiatry and biobehavioral services at the School of Medicine at UCLA. We are also part of the Addiction Technology Transfer Centers. If you're not familiar with those, that's a SAMHSA initiative that's designed to provide the most up-to-date substance use treatment information to providers in multiple different health settings. I make mention of that just to orient you to some of those different affiliations, but I'm also going to bring that up as a potential resource for all of you as we move through the training. So keep that in mind. Again, I mentioned that I would talk a little bit about myself as we go through. I'm not going to give you the whole resume, just a couple different items that I'm particularly interested in that I'll hopefully bring to bear as we go through today. I've been a clinical specialist at ISAP since about 2014. In addition to that, I teach at the UCLA Extension program for the Drug and Alcohol Certificate. That is training substance use providers to get ready to sit for certification and to pursue careers in substance use treatment. I teach the practicum course there. I've also designed from the ground up a 11-week self-care course for addictions professionals. And so those are a couple different interests of mine. Prior to this, I worked, as Dr. Fallender mentioned, what used to be Los Angeles Child Guidance Clinic. I was a program director there. That's in South LA, if you're not familiar with that organization. And so we were working with underserved, lower SES clients, and my role was to serve as an access director. So I was focused on how do we get people into the right kind of care at the right time, and that's a particular interest of mine. That involves screening and good assessment processes, certainly, but it's also relevant to engagement, and how do you make sure that people are engaged as best as they're able to. Ashley, I see you in the chat. The information, if you joined after I put it in there, totally fine. I'll put up a slide, and so you'll be able to join once we get to that activity. So don't worry about it right now. We'll certainly get to that. A couple other things that I've done. I'm interested in trauma-informed services. I was part of a national collaborative to enhance trauma-informed services. And that included building a one-of-its-kind wellness center that sought to reduce health disparities around individuals who had been exposed to traumatic events in their community. I have a background in first episode schizophrenia research at UCLA, and so one of the projects that we worked on was looking at combining physical movement or exercise interventions along with traditional cognitive behavioral interventions for schizophrenia, for first episode schizophrenia. And so again, I'll talk a little bit about that as we go through today. I'll share some of my experiences, but ultimately I'm really interested in hearing about what you all are encountering. And so there'll be plenty of opportunity to talk with each other, to talk with me, to establish some dialogue. Even though this is a remote, somewhat removed medium, I still really like interactive trainings. I think it's one of the most effective ways for adults to learn. And so we're going to bring some of that to bear as we go through today. There are a number of vignettes that are placed throughout the training. We'll see how many we get to, depending on time and the discussions that happen. If we don't get to all of them, I'll certainly make those available to you so that you can read through those. But the idea is that we're really trying to enhance thinking about practical application of clinical supervision. All the vignettes that are placed in this training have some significant degree of truth from my own experiences. Certainly they've been de-identified. They are maintaining confidentiality, but they are all based on experiences that I've had in my clinical work. And so I'll share that with you as we go through today. What we're going to work on as we move through today is really looking at best practices. How do you implement different practices within a community health setting to address chronically mentally ill and substance misusing clients and the functional impairments that they experience? We also want to think about multicultural and intersectionality considerations, both with respect to those clients, but also how those come up in supervision. There's sometimes a parallel process there. There's also sometimes an obstacle that can present itself when there might be a cultural mismatch, or when somebody isn't aware of certain biases that they may have, if they're perpetuating certain types of stigma. And as we go through and we talk about that, we want to think about that as a teaching or learning opportunity from the supervisory standpoint, not necessarily something to be punitive about, not necessarily something that's going to indicate that somebody can't function in the field, but what can we as supervisors do to support individuals who are doing this really difficult work. And then we'll take a look at different strategies to address that bias in working with co-occurring disorder populations. Just one caveat around this, what this training is it's not a co-occurring disorders 101 training. It's not a substance use disorders 101 training, even though we do have that, and so I'll link you to those resources at the end of the training. This isn't meant to go over the basics of substance use disorder or co-occurring disorders from a clinical presentation standpoint. Certainly that's not mutually exclusive from what we're talking about here, but really what we want to do is we want to focus on how does this come up in supervision? What are the challenges that providers face? What are some of their own individual biases, their own expectations that come to bear that might impact their ability to be effective in treatment? This is also not an overview of general supervisory practices or supervision models. I think you're getting enough of that with Dr. Goodyear and Dr. Fallender. So we'll talk about a lot of that, but this, for the most part, presumes that you have a basic understanding of substance use issues, of mental health issues, of different categories of substances, of different supervision models. And so as I'm going through this, I'll talk as if we're on the same page around that. If there is a question that you have, I haven't heard of that substance before. What do I do when somebody talks about popping certain pills? Certainly put those in the chat. And if we get to them, if we have an opportunity to get to them, I'm happy to talk through that. I'm also happy to answer questions offline if needed, and I will direct you to as many resources as I can to inform you about those different items if you need a little bit of a refresher. Just right off the bat, if you're looking for enhancement related to substance categories, uppers, downers, and all-arounders is kind of the go-to textbook that we use. We use that in the extension program. We use that, again, in our substance use disorder 101 training. That is probably the best textbook to orient yourself to the different categories of substances and the impacts of those substances, as well as how they might present in treatment. So again, I'll try to present some of those different resources as we go through today. You will have 2 websites on the very last slide, and these slides will be available to you that have our websites. Our websites, we post all of our trainings. We link to different online resources, and I'll go through all of that as we get towards it. But we're going to start off with this Poll Anywhere activity. And so what I want us to do now is I want you to think about supervision of co-occurring disorders, specifically co-occurring disorders. When you're supervising co-occurring disorders, what comes to mind? And so when you go to the website, when you enter via text, you can simply just type in what comes to mind when you think about supervision of co-occurring disorders. And so great, we're getting some really wonderful responses. Complex is jumping out. Complexity, that I think stands out to me in this cloud. And so keep entering your responses, and we'll hopefully see this advance kind of in real time as you're entering those responses. Frustration, yeah, that's good. I think complex is jumping out at me again. That one I think is probably the word that comes to mind most frequently. Let's see. Good. So I think people should be able to enter some responses. It looks like it's updating slowly. And so if you're still able to enter responses, keep doing that. And we'll see if this will evolve for us. That's great. Yeah, frustration is one of those components that we're going to talk about in a few different ways today. Again, frustration might be frustration with your supervisee. It might be frustration with potentially our own discomfort or maybe even lack of knowledge around what we're trying to work with. And so think about that as we move through. Frustration certainly contributes to other obstacles in supervision and treatment. You're looking at it contributing to burnout, adding to the potential for people leaving the field. Let's see if this changes things if I go to this. All right. It looks like maybe you're entering responses. If you aren't able to do this via the web or text, you are welcome to add information into the chat in terms of what you think of when you think of co-occurring disorders. Complexity is the one that I think stands out the most. And there are so many different challenges to manage, so many different potential targets of treatment to think about. It's often multimodal. You'll have to integrate care when you're thinking about effectively working with co-occurring disorders. That one of the things we want to do is think about how we might reduce some of that complexity. What are some of the opportunities we have as a supervisor to sift through some of the distractors that might come up with co-occurring disorder treatment, really getting at the heart of mobilizing people in order to move towards recovery, both related to substance use issues, mental health, as well as physical health issues. I see Michael in the chat. I also think of medical issues and medical risks, such as drug interactions with the substance and risk of withdrawal, certainly. And so we think about interactions from a behavioral standpoint, from a cognitive or emotional standpoint, but you also have to recognize the physiological impact and how that presents risk as well. We'll talk a little bit about that. I think that's embedded in at least one of our cases, thinking about the physiological piece of mixing different substances or potentially deviating from a prescribed medication with recreational or substance use issues. Good. Excellent. Thank you all for participating in that. Again, that's just one of the interactive activities we're going to be doing today. We're going to be doing quite a few more. And so we're going to start by thinking about principles for intervening with consumers with co-occurring disorders. I'm going to start right off the bat with this vignette. We're going to be talking about SAM. This is an intensive outreach case. And so a supervisee brings a new case to supervision. They talk about the case involving the provider needing to engage a homeless client as part of an intensive outreach team. Client's referral reports a history of schizophrenia, bipolar disorder, conduct disorder, methamphetamine use disorder, and regular alcohol and or marijuana use. The supervisee tells you that they have no last known address for the client, but the referring officer noted that the client likely lives on Skid Row currently. And so again, presuming that your treatment hasn't changed substantially, I know a lot of the more intensive programs are still outreaching to clients. They're still exhibiting appropriate social distancing as much as they can, but they are still out in the field. They are still doing the work that's required to engage clients. Thinking about this, what is your recommendation for making initial contact with this client? All of these dynamics considered, just thinking about that initial contact, what's your recommendation? And as you're thinking about that, feel free to unmute yourself. Feel free to chime in via the phone, or you can also put that into the chat. But thinking about that, what would you recommend as the supervisor, your supervisee do to make initial contact with this client? And I see L. Madrigal in the chat also noted high risk for additional problems, medical, relapse, multitasking. Good, yeah, I think as many tend to. High risk individuals, medical problems, relapses, social isolation, certainly, right? Yeah. And so even talking about accessing services, here we have a good example of that. What happens when you're being told you have to go out, you have to find this person. The person may or may not know who it is that you are, what it is that you're trying to do. Contact authorities to assist. Good. Bring food. I love that one, Jamie. Good. And Ashley mentioned contacting authorities. Good. Suggestions. Call them on the cell phone if they have it. I love that, Lori. We typically might think, oh, gosh, if somebody's homeless, there's no way to get a hold of them. But research has actually found that more individuals are more likely to have an internet-connected cell phone than they are to have a desktop computer at this point in time. And so while somebody might not have a set phone number, individuals are likely to have, depending on when their phones are activated, the opportunity to be contacted via Facebook Messenger, via WhatsApp, and some of those different messaging services. Take a team member with you. Certainly, Alex, I love that suggestion. I don't know that I would send a provider out to manage this just on their own. Safety precautions, buddy system, certainly good. Need to assess for risk issues. Going through this ahead of time with your supervisee to anticipate some of those potential risks is going to be critically important. You're not going to cover everything before they get out there, but knowing a little bit of what might come up is going to be important. Having a buddy in order to do that reduces some of the potential risk related to just going to Skid Row and trying to engage the client. We have this program at the county. We collaborate with substance use team. This is, let's see, we go out on a collaborative outreach as a team. If they're aged, a collaborative team can be with APS, if they're 65 plus. Medical concerns first, yep. So we might want to think about what are the basic needs that we might need to consider for this individual. Fantastic, that's good. Homeless outreach staff to engage in trust building and rapport, collaborate with law enforcement to address immediate safety issues. Good, really, really good suggestions. The thing that stands out to me is don't do this alone. Don't think that a provider is going to be in an intensive situation on their own. It really highlights the need for a team-based approach. And hopefully you have contract services that are that facilitate that team-based approach. If you don't, think about how you might integrate different treatment providers in order to best serve this client. That having a specific homeless outreach staff or team is critical in this day and age with the challenges that come along with housing related to stabilizing substance use issues and mental health issues. Buddy system might include peer support staff, right? So you don't want to necessarily just have a team that is a law enforcement officer, a psychiatrist, a mental health professional, and a certified substance use provider. That could be really intimidating and really off-putting. You might want to think about incorporating peer navigators, somebody with lived experience, somebody who's a paraprofessional who can outreach in a different way. Good. Excellent suggestions. I love those suggestions. I think we need to think about treatment as kind of breaking the boundaries of typical one-on-one office visits, especially when we're thinking about the dynamics of co-occurring disorder treatment. Good. Those are all really great suggestions. We're going to leave Sam here for the moment. Part one, we'll come back to part two, but I think, again, when we think about making initial contact, the thing that I want to consider is we have a last known address. We have the opportunity to build a treatment team. that might include the referring party. How do we put the right pieces in place in order to try to go out and engage this individual where they are, literally meeting the client where they are. Consider trauma as a foundation for the individual, absolutely. So as I'm going out, I want to think about doing nothing that's going to potentially re-traumatize this individual. Again, there are certain things that we can do to plan for that ahead of time. There are certain things that we might have to respond to in the moment. And so being trauma-informed is going to be really critical. Part of that in supervision is also making sure that the supervisee feels safe, supported, and capable of navigating this particular case. Good. So we think about trauma-informed, both outreaching to the client, but also within the supervisory process. Excellent. We'll come back to Sam in just a little bit. Let's talk about some of the principles of co-occurring disorder treatment. And I want to bring this up just to orient us to what we're going to be talking about. Mental health and substance use treatment are integrated. They should be integrated to meet the needs of individuals with co-occurring disorders. Now, that sometimes happens better in certain facilities than others. I know that there are still numerous facilities that focus on one versus the other. We still do trainings in which people will say, well, I don't really deal with mental health stuff. If somebody talks about risk, the therapist needs to handle that. And we also have mental health providers that will say, yeah, I'm not really comfortable talking about alcohol. When that comes up, they just need to talk to their counselor about it. And similarly, with physical health issues, diabetes, obesity, hypertension, I can't touch any of that because it's not my scope of practice. True, we want to be cognizant of our scope of practice, but there are always things that we can do, especially from a behavioral, cognitive, emotional standpoint, to still support an integrated treatment approach. And as a supervisor, we need to think about how we hold those different components for our supervisees, because it can be incredibly complex, as you all noted, which can be overwhelming. Integrated treatment specialists are trained to treat both substance use and serious mental illness. So we don't have providers that are specialty trained in just one area of treatment. They really are kind of the Renaissance providers where they can do all these different types of treatment. Co-occurring disorders should be treated in a stage-wise fashion. So thinking about Prochaska and DiClemente's stages of change model, we'll get to that in a little bit. Your services should change, and the way in which you apply those services should change depending on the stage that an individual is in. And so I don't think about all treatment as being equal at all points. I think about this along a continuum. I think about this as an ongoing chronic need for support that may look different at different points in treatment. And so think about this via stages. It helps to orient us to cut through some of that complexity, but it also helps orient providers to be more focused on critical issues. Good. MI is critical. And so I look at these two treatments, these two treatment interventions, motivational interviewing and CBT, as foundational components for addressing co-occurring disorders. There are certainly other types of theoretical orientations that you might bring to bear, other theories, other models, but these are the two that I emphasize most with providers, whether they're novice providers or they've been in the treatment field for a long period of time, because it really helps, again, to orient us to what is necessary to stabilize the individual at this point in time. And so we'll look at these two types of treatment interventions as we move through today. And I'll give you a little bit of information around MI and CBT, again, presuming that you've had training in those, whether you feel proficient or not. And so this fits nicely with a developmental or stage-wise approach. And so we'll look at how those two interact with each other, how they supplement each other in treatment, but also what some of the limitations might be from a treatment and supervisory standpoint. We have to think about multiple service modalities, individual, group, family, case management, self-help groups, community-based groups, spirituality engagement. All of that is critical to think about when we're trying to wrap comprehensively around an individual who's experiencing multiple different functional impairments. Medication services are integrated and coordinated with behavioral and psychological services. And so this isn't a separate silo. It's not considered as separate. We're really looking at integrating that specifically. And I think you all are aware of the need for those different principles. I just wanted to go over these 7 different items, again, to orient us to what we're going to be talking about today, to serve as a foundation for how we might conceptualize guiding a provider in supervision. A word of caution before we get going into more of this information. It's important to recognize the interplay between case management and counseling/therapy. Many of you have providers who have a dual role as case managers and counselors or therapists. Both are essential. You can't really comprehensively and effectively work with co-occurring disorders unless we are addressing case management issues. This came up in our initial discussion of looking at foundational needs. When you think about Maslow's hierarchy of needs, you think about that most basic level of biological needs or physiological needs. Reconceptualizing that for a substance use or co-occurring disorder client, that most basic level, the biological and physiological needs, as somebody mentioned, we think about withdrawal, we think about the physiological impact of substances. That most basic level is going to be all consuming for an individual who's using substances. And so thinking about self-efficacy, thinking about activities that somebody may be engaged in related to recovery isn't going to be the best starting point because we haven't addressed that most basic need. Case management helps us to stabilize some of that. And so it's easy for providers to become wrapped up in case management while minimizing the focus of counseling and therapy because we're so pulled towards putting out those different fires related to the individual's environment, different aspects of their functioning in their home related to vocational or educational attainment, trying to get to meetings, trying to get to appointments, that sometimes we see providers shifting to solely doing case management. And that might not necessarily be a problem early on in treatment, but where it starts to become an issue is when you have your provider, you're checking in with them and they say, yeah, you know what, I was at the court, I was talking to the PO, I was trying to coordinate with the psychiatrist this week, we went down to the food pantry, we also had to talk to DPSS about trying to get their services initiated, and so I was filling out a lot of paperwork with them, I was on the phone a ton, and we really need to find some way to stabilize this individual financially. If I'm not hearing a lot of consideration related to enhancing motivation, enhancing self-advocacy on the part of the client, thinking about recovery-oriented skills, both for substance use and mental illness, I want to shift that individual to thinking about how do you make that client more self-sufficient? Even if it's not going to happen right now, even if they need a lot of support right now, what can I do as we're progressing to have that plan in place so that the supervisee can orient themselves to a more longitudinal conceptualization of treatment rather than just putting out fires right now, which often makes the client more dependent on that supervisee. You want to promote proficiency in assessment, specifically the assessment of needs for case management and the application of different case management models. So intensive case management or ACT is also a really good case management model for intense co-occurring disorders. ACT is going to be a little bit more difficult if you don't have the resources or the funding to do that kind of assisted community outreach for case management services. But that is a good program that's similar to Wraparound if you're familiar with that. And then we want to use this in conjunction with different evidence-based treatments for co-occurring disorders, like MI, like CBT, to name a few, but we'll talk about more as we move through. We want to make sure that we are effectively supervising individuals. When we look at substance use treatment information, there isn't a lot of information out there. So we have some good information around different models for clinical supervision related to mental health. But when we look at data-driven models for supervision, specifically related to substance use and co-occurring issues, research has found that those are virtually non-existent. And we'll talk about why that is. But if that doesn't raise a red flag for you, it should. That's certainly a major concern of mine in the practicum course that I teach. Are you getting regular supervision? Are you meeting with your supervisor regularly? Are they using any sort of data to drive supervisory processes? Are they using a structure in supervision? Unfortunately, there's also little known about clinical supervision in addiction treatment. Historically, addiction treatment hasn't been standardized to the level that would allow for this kind of rigorous data collection that would inform our processes and procedures. I think there are larger programmatic shifts that are happening currently that will facilitate this in the future, but it's kind of the wild, wild west at this point. And so unless somebody brings up that they're not adequately supported, One, they have to feel comfortable to do that. Two, they have to recognize what good supervision actually looks like. If they're not bringing that up on their own, they might be out there trying to navigate all these different challenges without adequate support. We see that effective clinical supervision has a significant impact on client recovery outcomes, that good supervision will account for some of the variance that we see in those outcomes related to substance use and co-occurring issues. We also see that supervisors and supervisees are misaligned in their perceptions of supervision. I see a question in the chat. Some agencies advise their outreach staff that their role is one of case management and that they should not be doing therapy. How does one deal with this system issue? I supervise several outreach workers who have told me this. Yeah, it's certainly a good question. I think within a certain organization, you're going to have different roles delineated and defined in different ways. It's great that there's a dedicated outreach team. I think, again, the needs are so numerous that having somebody focus on case management is critical, but where is that therapy coming in? Because we need to make sure that we're thinking about these needs for every individual and trying to individualize the case management piece as well as the therapy piece. Alex says, my suggestion is case by case and making it short term. That's great. Again, short-term case management, stabilizing an individual, thinking about how we might get them into treatment, into integrated care is going to be really critical. And so what is kind of the long-term opportunity to think about that? And when I talk about long-term, I'm not thinking about years. I'm thinking about potentially just weeks or months. If we do that good targeted outreach and case management, fantastic. What happens with the therapy piece? Who's responsible for that? Is there a therapy team within that organization that can be linked to, that can work closely with those case managers? Or is it the case that you'll have to refer out, which certainly makes it a little bit more difficult to coordinate care? So I think having a dedicated team is not necessarily a bad thing, as long as there's an opportunity to utilize resources in an integrated way. Yeah, good question, Michael. Yeah. So we see that supervisors and supervisees are misaligned in their perceptions of supervision. That's not good, because if you're not on the same page with your supervisee, there's going to be misinformation, there's going to be a lack of understanding of their role and your role, and that's going to translate to potentially less effective application of some of the skills we're talking about. When we look at effective components of clinical supervision, especially in substance use treatment or co-occurring treatment, sponsorship, challenging assignments. I think there's no lack of challenging assignments for our providers. Role modeling, and so as a provider, making sure that you are modeling some of the skills that you're expecting the supervisee to be able to deliver or impart. Acceptance and confirmation, again, that goes along with that engagement piece and building the supervisory relationship. And then supervisor task proficiency. We're going to talk a lot about trust and the relationship, and I know this has come up on other sessions that you've had. Supervision is not therapy. Supervision is not coming in and crossing those clinical boundaries where somebody is going to be talking about their deepest, darkest secrets and all the challenges that they're having in their personal lives, but that does come up. And so it's important for you as a supervisor to find that balance between role modeling, sponsorship, acceptance, and confirmation with keeping the boundaries appropriate to clinical supervision. Clinical supervision, especially of substance-related treatment, tends to be unstructured and informal. Again, if we're expecting our providers to impart some degree of structure and consistency with clients, we should think about how we're doing that in supervision as well. They find that regular supervision is not guaranteed. One study found that 30% of substance use providers were not receiving regular supervision. Again, one of the components at UCLA for practicum that we require is that there's regular supervision, there's regular involvement in sessions by supervisors. It's not acceptable for especially a newer provider in the field to be left on their own to try to navigate the challenges of co-occurring disorders. The development of critical substance-related interventions is often left out, and so we tend to defer to one component of treatment rather than thinking about this in an integrated way. Supervisors tend to rate time spent on tasks within supervision and the impact of supervision higher than supervisees, and so I think that speaks to how we see ourselves as supervisors, we tend to rate what we're doing at a higher level than what supervisees experience. And then these within dyad discrepancies are often reflective of lower satisfaction in supervision and less frequent discussion of critical elements, which again is not going to be conducive for facilitating recovery. We want to make sure that we're reducing these discrepancies so that my expectation of supervision is the same as my supervisees. Looks like H.N. Sylvester said, I also talk about the idea of planting therapeutic seeds when doing case management. Great. Yeah, we are often doing both with these individuals. Yeah. I often think about case management like breathing. Nobody thinks about it until your attention is drawn to it. You're always doing case management in one way or another. But just like with breathing, the more intentional you can be about it, the more effective it becomes in terms of cultivating health. And so focused breathing, mindful practice, structured practice is really great. If you have a case manager and it's outside of their scope of practice to provide therapy, what kind of behavioral interventions can they drop in those interactions, those little seeds, those little nuggets of therapy-like interventions that might facilitate motivation, that might facilitate the development of some type of coping mechanism? That's a really, really wonderful suggestion as well. And it's part of that balance that we have to strike. We don't want to lapse too far in one direction or go outside of our scope of practice, but there's always that opportunity to be forward thinking in how we apply some of those additional components, regardless of what our role is. And I think that's true, again, cross-cutting between mental health, physical health, and substance use issues. Great suggestion. If we look at where those discrepancies occur in supervision, most often we're seeing discrepancies between discussions around client relationship and rapport and the use of evidence-based treatments. Those are the most significant when you're looking at counselor report and supervisor report of the discrepancies that come up in supervision. That's pretty critical to me, because one of the things that we know, particularly around substance use treatment, is that if you're not engaging someone, if you're not building rapport initially, you're going to lose them. If you aren't able to keep that person in treatment for 30, 60, 90 days, they are less likely to demonstrate positive outcomes. And so the development of that therapeutic alliance, that relationship, is critical, and it should have its due in supervision. We have to have some evidence base for what we're providing to clients. And we have to have some standardization. Otherwise, it's based on anecdotal evidence of what works and what doesn't. And that can be really problematic, especially when it comes to substance use treatment. So a focus on evidence-based treatment and the appropriate application of that should be a priority within supervision as well. While most counselors do rate their supervisors as effective, that's kind of that middle point of the scale, the researchers actually argued that our standards should be very effective for how effective we need to be in clinical supervision. Effective is just kind of a middle of the road. Things are progressing fairly well. There's no major conflict, but that doesn't necessarily translate to the types of positive outcomes that we want to see with clients. So supervisors report spending more time on supervision activities than supervisees do, and using a greater diversity of modes of interaction. So supervisors might report email, texting, calls, whereas supervisees may not recognize that as supervision. This becomes really important when you think about the multiple different demands that you have in your organizations between administrative tasks and clinical tasks. Oftentimes they get lumped together, and supervisees will see just the administrative piece, which feels less impactful from a supervisee standpoint. So I want to be clear about the supervision activities that I'm going to be utilizing with the supervisee ahead of time and as I'm doing it, trying to keep the boundaries of supervision as neatly defined as possible, as big of a task as that is. Education varies significantly among clinical supervisors in substance use treatment as well. So this is substance use treatment settings across a wide variety of levels of care. This is from NIATX's endeavor to enhance data-driven and evidence-based treatment across the country. So they've pulled different facilities at different levels of care. They might be co-occurring, they might be standalone. But what they found is that among substance use, among providers, clinical supervisors in those settings, the supervisors reporting some substance use disorder education, 15% said none, half said some, 35% said a great extent. Related to mental health education, 6% said none. 31% said some, and a little bit over 60% said a great extent. So a little bit more encouraging there, a little bit more mental health education than, surprisingly, substance use disorder education. And then related to clinical supervision education, almost 40% said they hadn't had any clinical supervision training or education. 57% said they had some, and only 7% said they had a great extent. Again, raising a red flag, incredibly concerning to me. I would want to see providers in almost any setting versed in co-occurring disorder treatments, and that's substance use and mental health, as well as having some opportunity to get clinical supervision training. I'm sure you've talked about this on your other sessions. Oftentimes what we do is we find the best provider, the one that's doing the best work, and we say, hey, do you want to be a supervisor? And we promote them with maybe a handbook that's been developed in that organization, but it's often learning as they go, or it's the game of imparting knowledge based on the supervisor that you're working with, which is not an effective way of really standardizing effective care. Good, it looks like IBOC, during outreach, a supervisor and encourage staff to utilize interventions that are useful, such as motivational interviewing. Good, which can be a diverse engagement. Good, yeah, again, I like MI as kind of that starting point because it really allows us to start broadly and narrow down specifically to the individual while taking into consideration different aspects of culture or intersectionality, as we'll talk about. It's great. 29% of substance use disorder treatment providers report being in recovery themselves. And so this is compared to almost 40% of counselors. And so we're going to try our first poll question here. I'm going to put this on the screen. Let me know if you cannot see this. I'm going to launch this poll, and there's going to be 2 questions here. You should be able to see that. So the poll is being launched. Remember that 29% of substance use disorder providers identify as being in recovery themselves. If you're having any trouble seeing the poll, just let me know, but you should be able to vote on this now. Which best describes your identity as a supervisor related to recovery? I know it seems like, Ashley, you can see it, so feel free to vote when you're ready. There is a second part to this. So the first part asks you about your identity as a supervisor related to recovery. The second part is, if you were asked directly by a supervisee whether you're in recovery or not, would you, 1, tell them, 2, not tell them, or 3, it depends. And so very good. All right. If you hadn't had a chance to respond to the poll, you can go ahead and share your information in the chat. I'll put up these results here. So it looks like 71% of you said, I am not in recovery and feel that does not make me any less effective as a supervisor. 17% said, I am in recovery and feel that makes me a more effective supervisor, interestingly enough. And so nobody said, I'm not in recovery, that makes me less effective. I'm not in recovery and feel that makes me a less effective supervisor. 8% of you said that. I appreciate you chiming in with that, because we'll take a look at an example. But depending on where you work, depending on your organization and how embedded in recovery culture you are, there may be some mixed messages about your efficacy that you may be getting from providers. 2% I prefer not to say, 2% say it doesn't really matter. And then if asked directly by a supervisee whether I'm in recovery or not, I would. Kind of mixed here. 54% said it depends. I love that middle of the road answer. I need more information. That's a very relevant way to answer that particular question for this group. 42% of you said that you would tell them. Good. I think transparency is critically important. I think it also brings up some of the supervisory dynamics that we have to take into consideration around bias, around our own values. What does it mean if you're willing to answer this question? I have no problem answering this question in trainings, in supervision, but I've also been in situations in supervision and in trainings where people have taken this in other directions, where you get other boundary crossing type questions, like, have you ever experienced a traumatic event in your life, which people may feel less inclined to share And so there might be some differences in the types of questions that you're asking, but if you're willing to answer this question, what is the implication when you get additional questions that ask about your own personal identity? So we'll stop with the sharing of those results and we'll come back to the poll in a little bit. Does identity actually impact supervision, or is it like Princess said, it doesn't really matter as long as you're effective and competent? It's actually been shown that it doesn't really play a significant difference in clinical care or supervision, whether you're in recovery or not. Just like in treatment, sharing and disclosing personal information can build rapport and connectedness, and so that can be a really worthwhile use of this. But just like in treatment, you have to be selective about what you disclose, because once you open up that can of worms or that Pandora's box, it's going to be a lot harder to set a boundary later on without potentially disrupting the relationship if you're willing to share some things, but not other items about your personal identity. So just like in treatment, we want to, if we're getting questions about our own identity, we want to make sure that it's within the confines and the boundaries of appropriate supervision, setting firm limits, but not being rejecting as you're doing that. And while there is evidence to support that being in recovery versus not being in recovery produces no different outcomes in treatment, conceptually or theoretically, recovering and non-recovering therapists tend to differ in their approaches. And so while the outcomes aren't different, the way that people approach treatment is different. And so I want to think about this from a supervisory standpoint. If I'm trying to standardize the evidence base for how we apply these different interventions, I need to understand a little bit about my own identity, what that means for how I approach treatment, and what that also means for my supervisee. The differences that you tend to see are the perception of substance use problems, the method of treatment used to address substance use problems, and different personality and attitudinal traits. So how somebody comes by it, which makes sense that if somebody has lived experience, they might draw upon that in a different way than somebody who's approaching it more academically, having read it, or maybe having had experiences within the confines of treatment. So let's take a look at Craig. Craig is co-facilitating a supplemental daily skill development group for individuals with co-occurring disorders. He tells you that he feels uncomfortable in the group because his co-facilitator, Rachel, is constantly drawing on her own experiences as an individual who is in recovery from opioid use issues. Craig feels like the group immediately identified with Rachel and feels that she was able to demonstrate more effective empathy than he could. Since Rachel set the tone by disclosing her own experience with addiction, Craig feels marginalized in his skill and has even recognized mounting anxiety about being called out as a normie, which is not unheard of in some of the groups that I've supervised or been part of. Craig blurts out, "It's not like I'm about to tell everyone how I'm constantly trying to manage my depression to win easy points with the group." How would you help Craig in this situation? What would be your approach to addressing this situation with Craig? And again, feel free to unmute yourself. We'd love to hear your voices. Otherwise, you can contribute in the chat as well. And while you're thinking about that, Dr. Fallender mentioned one of the discrepancies in supervision is supervisees knowing MI and supervisors not knowing MI, which is actually pretty common, and vice versa as well. I remember there was a time I was working with a group of it was field-based services, and they were trying to outreach to a client, and I said, well, this sounds like a great opportunity to use motivational interviewing. And they said, yeah, that sounds really good. We're going to do that. And they came back in the next time after meeting with that client. I said, how did it go? And they said, we realized we don't know how to do MI. And I said, well, that probably wasn't a great suggestion then. And so we had to take a step back and figure out what is it that we need to do to enhance those skills. Good. What are you going to do with Craig? What do you think would be an effective way of trying to manage Craig's mounting anxiety in supervision?
I might, oh, sorry. Was somebody else going to talk? Sorry.
Nope, go ahead.
Oh, okay. I was just going to say, I might try to normalize his anxiety about it so that he doesn't feel like different for feeling anxiety about being normal in the group, and try to help him kind of perspective take as far as Rachel's approach, and as to how that's helpful for the group. Yeah.
Nice. So trying to address his own anxiety, building some self-efficacy around his own skill, identifying what he does bring to the group, while also perspective taking, recognizing what is the strength of having Rachel in the group and how do they play off of each other. That's great. Thanks, Ashley. And then I think H.N. Sylvester, you're going to add something?
So one of the things that I have always just being in recovery, I've learned that just because I'm in recovery doesn't mean my recovery story matches with other people's recovery stories. So it's
exactly,
sharing that with Craig and saying that it doesn't matter about having a story that matches the other people in the room. If you are genuine and compassionate, that is what does a lot of the engagement process. So what part of you can you genuinely bring into that room? And helping him to hone those skills and figure out how to bring himself and that professional use of self in that room versus focusing on that role identity, because it doesn't, the clients are going to be much more concerned about who he is rather than his story.
Right. Good. It's about how he is in that group. How does he support the individuals in that group? How does he build engagement? And you hear a lot of the MI coming out, that spirit of MI, even just in potentially that supervisory interaction. How do you cultivate Craig's values around what he's bringing to that interaction, similar to what Ashley mentioned, while reducing the anxiety around how he might be perceived? I love the idea of, even if you don't necessarily disclose, I'm in recovery myself, and I know that my story isn't everybody else's story, presenting that as information for Craig. Look, nobody's story is exactly the same. They might feel connected with Rachel, but you also have to be really careful about not presuming that the things you've experienced are the same for everybody else. And so having that little bit of distance might be beneficial to Craig. Good. I like that. Looks like there's some good activity in the chat. April, I would ask Craig if there was any evidence that the group shifted in their opinion of him, or is this his own thinking? Really critical to note. Is this a group process that needs to be addressed in some way? Or is this Craig's own anxiety? Is there something going on in Craig's work that's making him feel less effective? Good, I like that. Looking at that discrepancy potentially. Let's see, Jamie says, explore with Craig why he felt the need to say what he said. Then explore how this may have affected the clients and his relation with Rachel. Yep, so again, we're trying to look at building up Craig's sense of efficacy, but at the same time, thinking about this within a dynamic of the group, but also the co-facilitation. I think exploring with Craig why he said what he said, making sure that he's able to navigate his work, and that he is managing his depression in a way that it isn't affecting his work might be relevant as a way of providing support. And then thinking about how that impacts his relationship with Rachel or his interaction with Rachel. Maybe that he's reading into what the group is thinking, into what the group thinks, reflecting his own security from Lori. Yep. And so we want to do a little bit of that cognitive examination. What are you noticing in the group versus what is your own insecurity or anxiety? L Madrigal, help Craig normalize his feelings, ask what, if anything, he can disclose to the group, and how he feels about self-disclosing. Yeah. Good, normalize his feelings. That it would be odd to be in that position. Excuse me. It would be odd to be in that position and feel like you have to be compelled to disclose something, but maybe not disclosing just for the sake of disclosing. Understand what that means and what that process looks like. Validating anxiety from I.O. Urbina. It's important to guide him to refocusing what he brings to the group. Good, and what and how he can bring that to the group. Rachel is his colleague. Discuss it with her. Yeah. That again, this doesn't exist in a vacuum, and maybe you might want to do a little bit of work in supervision if there's some resentment there to try to talk about that by building Craig's efficacy, but having a discussion, having them sit down together and plan together how they can be effective. It's good. And then Alex said, I would also recommend that Craig share these feelings with Rachel. Good. Again, yeah, so bringing them together. How can they work together as a team? They're co-facilitators. They're in it together. They need to work on building on each other's strengths, address the challenge as a team. I love those approaches. Again, it's not out of the realm of possibility that Craig would be called out and that somebody might say, oh, you're just a normie. So how do we address that? How do we prepare Craig to be able to navigate that situation and not react defensively, to not say, well, research shows that I'm not any less effective. You don't want to go that route because that's not going to be effective. So planning for that conversation is going to be critical. And I think having a conversation with Rachel allows the facilitators to support one another should that come up. I'd also like to navigate the excluding behavior by saying normie. I would also like to align with level of empathy and create rules for a safe environment. Translate that to group rules that somebody may say that off the cuff and might not mean anything by it, but we want to try to use language that isn't marginalizing. And that kind of segues, really good segue, Nanette, to everything that we're going to be talking about in the next few slides, that it's not just about whether you're in recovery or not. The type of language that we use as providers and how we model that with our supervisees, with clients, really does play a role in treatment. That's great. Really good discussion. I appreciate that. Everybody in the chat, as well as those of you who chimed in via the phone. So some practical suggestions around supervision. Ongoing training is critical. We have to understand supervision models, and that has to be an ongoing endeavor. Adapt those models to incorporate substance use and mental illness specific components, including the evidence-based treatments that we're talking about. Use data to drive feedback. And so it's not just off the cuff, hey, it sounds like you're doing pretty well this week. What mechanism do we have to actually note, outside of things like the number of notes you've written or turned in? What mechanisms do we have to provide positive as well as constructive feedback to supervisees? And again, continue getting training for evidence-based interventions for co-occurring disorders to hone your own skills, and emphasize the development of relational skills as critical. Active listening, motivational interviewing, summarizing, providing feedback are all best modeled by a supervisor. And so as a supervisor, we say active listening is critical. Empathy is critical in developing relationships. How do I demonstrate that as a supervisor? Really quickly, I'm going to talk about 3 different levels of provider competencies in supervision related to co-occurring disorders. And so there'll be a poll after this. I want to understand where you see yourself. But these are general guidelines for the development of these 3 different levels of competencies. At the most basic level, you're comfortable as a supervisor helping your client, your supervisee, understand basic screening for co-occurring disorders. So you could talk about what to look for. You could talk about how to complete those forms. Conducting a preliminary screening of danger and risk is critical, both related to physical health, substance use issues, and mental health issues. And so you wouldn't necessarily have to assess that in detail, but screening for it. Engaging clients in such a way that they enhance and facilitate future interaction. That's that engagement piece, that relationship building that we talked about. De-escalating the emotional state of a client who's agitated, anxious, or angry. So that de-escalation, rather than moving right towards, we need to hospitalize this person because they're agitated. How do you take the opportunity to de-escalate and recognize situations where de-escalation might be indicated, whereas it's a unavoidable hospitalization situation? Managing crises. So again, that's threats of suicide or harm. That might also mean involving other providers to either assess further or to complete a hold, referring clients to appropriate mental health or substance use or physical health facilities and other referral sources, and then coordinating care. So this is really that most basic level: recognition, addressing critical needs, and then coordinating care. At the intermediate level, integrated diagnosis. So are you looking at multiple different sources of information to assess and diagnose substance misuse and mental health issues? Integrated assessment of treatment needs, integrated treatment planning, engagement and education around substance use as well as mental health issues. You're using early integrated treatment methods. So that's crisis response, access to treatment, and integrated treatment team services, when and how to refer or communicate to other organizations. And then longer term integrated treatment methods, that might be group treatment, relapse prevention skills, doing case management, integrating pharmacotherapy, those evidence-based treatments we talked about, something like seeking safety that you might use in a group modality or as an individual one-on-one application. Are you comfortable as a supervisor comprehensively describing these different components? Things like 42 CFR Part 2, substance use treatment has its own set of confidentiality standards that it would be important to know about, again, depending on your organization and who you're working with. And then the most advanced level is, do you understand the trans-theoretical model as it's applied to behavior change? Can you adequately apply motivational enhancement skills with your supervisee to build up their motivational interviewing capacity? Are you aware of the relapse prevention model and how that integrates into mental health treatment as well? Can you diagnose based on the DSM-5 criteria? Do you understand the effects of different levels of functioning? Do you conceptualize substance use issues consistent with current research as an ongoing chronic condition? And then are you able to involve different treatment team members as well as the family members and other service providers? So again, here you see we're taking this to a higher level where we're using the DSM-5, we're using specific models and practices in order to facilitate the supervisee's development. What we want to think about is that people with serious mental illness tend to experience significantly reduced years of life, and that's critical to consider, that this isn't just, you know, it's difficult to manage in treatment. It really does have a bearing on the way in which people's health is affected. And so I want to think about this when I'm talking with supervisees. I'm not going to go over this information all that extensively. I think you're all aware of this, that if somebody's coming in with a substance use issue, they're significantly more likely to have a co-occurring mental health issue than vice versa. What I do want to go to next is, we'll take a look at, let's see, we'll talk about SAM, and then we'll be able to, we'll take a little bit of a break after we talk about SAM. So following up on SAM, the next time that you have supervision with that staff member, they report that they were able to make contact with the client. Upon arriving at the client's tent, the team was greeted by an individual who pointed the team towards a naked individual who was lying on the side of the street, identifying that individual as Sam. Upon approaching the client, the team realized the individual was drinking the runoff water in the street. The client appeared lucid, though slurring his words slightly and displaying distrust toward the team and some paranoia about the team's visit. What is your recommendation for engaging the client, and what type of support do you think the supervisee would need at this point in time? So again, feel free to unmute yourself and chime in, or we can go to the chat.
I might start by giving him clean water.
Good. Good, clean water is going to be critical, yeah. Let's see, evaluate 5150 first. So we want to do a risk assessment. Is this person able to engage in any way? I would remind Sam who we are, so that we're here to help, ask if we could assist him in any way. Client's level of consciousness. Is he so gravely disabled that he wouldn't be able to understand you? Good, so we're looking at just kind of determining the individual's orientation before we do anything else. Yeah, good suggestions. Assess for grave disability. Sounds like Sam is gravely disabled. We need a 5150, look for medical needs, a risk assessment. Supervisees need assistance in how to effectively communicate with the client while maintaining safety. Yeah, good. Good, so one of the things that we want to consider is how do we determine whether or not this individual is gravely disabled? Is this a 5150 situation? Or is this a situation where we have the opportunity to potentially do some degree of engagement, communicate with the individual while still maintaining safety and conducting these risk assessments? Again, this is a case that actually came up. This actually came up we were thinking about how we could actually apply motivational interviewing with this particular client just as an exercise. Obviously, probably not the best intervention to apply with this individual because they probably aren't going to report a lot of motivation, but observation and conversation, I like that. thinking about how do you still engage the individual to the extent that you're able to. Consider medical intervention based on drinking potentially contaminated water, which could result in present condition. Engagement needs to be done safely, non-threatening, in a supportive way. Yeah, so there are a number of potential targets that we might think about. The medical issue as a result of drinking the runoff. This could potentially be substance-induced. It could be mental health-induced. We don't necessarily know what the client's baseline level of functioning is. And it seems like we probably won't get at that in this particular session. Now, this may be an opportunity, as Elle Madrigal pointed out, providing basic needs first. That when we're talking about looking at motivation, the motivation here is water, maybe some food, maybe some clothing, something to stabilize those basic needs before we even get into the treatment part. That seems a lot like case management, but at the same time, we're doing something very specifically therapeutic in engaging this individual, in noting who we are, what we're there to do, and providing some of those supports. Good. Really great discussion. I think this is an appropriate time to take a break. I have 10:23, and so we're going to come back exactly 15 minutes from now.